So hello to everyone who is joining us on Zoom. A big hello also to everyone who is joining us via Facebook. We're so excited to have you here with us today. My name is Emily Lemiska, and I am Director of Communications and Educational Programming for US Pain Foundation. And today we're going to be talking about all different types of neuromodulation therapies with Dr. Leong. And we're very, very excited about this because I've never really seen a presentation like this. And, you know, we do a lot of presentations here at US Pain, so it should be an excellent event. So our agenda for the day is just a few housekeeping items at the beginning with me. Then Dr. Leong will give his presentation, and then we will open it up for questions, which I know we've already gotten a lot of great questions submitted. So we'll try to get to as many of those as possible, and then we'll have a quick wrap up at the end. So we'll try to be about an hour. So just some general items for you to know. You've probably noticed that attendees are on mute and your cameras are off. You can ask questions by typing them into the Q&A panel, and that should be in the bottom of your screen. Again, we'll try to do our best to get to as many as we can, but we're talking about such a huge topic today. We might not be able to get to everything, but we'll definitely do our best. And feel free to follow up with your question via email if you have something that we didn't get to. Just a quick note too, Dr. Leong can't give you specific medical advice, so try to be a little general when you frame your question. He is not in any capacity your medical professional, and it's important to always check with your specific provider to give details on your specific condition. We do have our chat open today, but please be respectful of one another, and please try to ask your questions in the Q&A, not in the chat, because the chat can get kind of busy and they might get lost in there. If you're joining us on Facebook, you can just type your questions or comments in under the video and we will get to those as well. So today is part of our annual November campaign, very clever, K-N-O-W-Vember. And this is something we do every year, and we pick a different area of pain management to focus on. In years past, we've done art therapy, we've done pediatric pain, we've done complementary medicine. So we tend to look at areas of pain management that are, kind of unique and maybe people don't know a whole lot about. So this year it's neuromodulation, and we have a special incentive happening this month where if you join 2 of our 3 events, you can receive a free awesome face mask that has the US Pain logo on it. You'll get to learn a lot about neuromodulation, but also free face mask is a great bonus. We had one event last week on Twitter, so sorry if you missed that, but you can find the chat on our website. We'll also have another event next week on November 19th. So if you want more details about those events or about the campaign overall or how to receive a face mask, just check out our website, uspainfoundation.org/November. I also wanted to say thank you to our sponsors for November, Boston Scientific and Abbott. This program was developed independently, but it was made possible through their support. And of course, our little disclaimer, we'll be talking about a lot of specific therapies today, but that does not mean that we endorse or specifically support any of them. The information is just educational. It's not medical advice, as I mentioned earlier. And again, always make sure you seek the advice of your healthcare provider, because as we all know, when we have chronic pain, we are all so different. So you have to make sure you talk to your doctor about what's right for you specifically. So with that, I'd like to introduce Dr. Leong, who we have here on camera. So Dr. Leong is a specialist in pain medicine who focuses on radiculopathy, spinal, abdominal, and cancer pain, post-herpetic neuralgia, and workers' compensation cases. He received his medical degree from Georgetown University in Washington, D.C., and completed his residency in anesthesiology at University of California, Davis, and at Stanford University, where he completed his fellowship in pain medicine. He is board certified by the American Board of Anesthesiology. He currently is the director of the Neuromodulation program, as well as a clinical professor of anesthesiology and pain medicine at Stanford. So we're very lucky to have him with us today. It's hard to get anyone more perfect for this talk than someone who is the director of neuromodulation at Stanford. So thank you so much, Dr. Leong, for being here with us. We really appreciate it, and we're very excited to hear from you today.
Look, Thanks everyone for tuning in, and it's really a pleasure to be here. Thank you for the invitation from the U.S. Pain Foundation, from Cindy Steinberg, as well as you, Emily.
Absolutely.
So I'm going to go ahead and try to share my screen here for a second. Okay, and share this. Okay. Let's go up. Sorry. I'm going to move back here for a second. I'm showing everyone some previews.
Spoiler alert.
Yeah. Get back. Okay. Where are we here? Okay. I have a few disclosures. And so, you know, even though I'm the director of neuromodulation, I have to admit, I've never given this kind of a lecture before. And it actually was really good for me, and hopefully educated me, as well as maybe educate you as well, about different kinds of neuromodulation that I don't typically talk about in detail during clinical visits. My disclosures are that I'm involved in a couple different pain management societies, the Pacific Spine and Pain Society, which is mostly a West Coast based pain management endeavor here. I'm also involved in a couple other national societies. The two consultant things are for some up-and-coming, medications that could be available for pain control in cancer and other kinds of nerve pain conditions. So let's start with this. And I know that all of you have tuned in that may have already heard the lectures about spinal cord stimulation and dorsal root ganglion stimulation, or DRG. So hopefully this will just sort of increase the knowledge base and broaden everyone about where everything fits in. But what's neuromodulation defined as? So neuromodulation is really the targeted delivery of something, the targeted delivery of either electricity or chemical agents, neuromodulatory agents at specific neurologic sites in the body. And I have to admit, throughout my career, mostly it has centered around the spinal column, because all nerves seem to come through the spinal column and then go to the brain that transmit pain. But now we've been branching out to not just the spinal column, but to the surface of the body and to the periphery, in order to really enhance our ability to treat different kinds of pain conditions in the least invasive way possible. Now, some of the common things that people know about are TENS units, or transcutaneous electrical nerve stimulation, and also spinal cord stimulation, which is electric signals there. And you may have heard of these pain pumps or intrathecal drug delivery systems, and especially for cancer pain, especially when people are on high doses of opioid medicines and they want to be treated in a way that doesn't cause side effects. Now, which device do you choose? Well, the only way that I could sort of group things together was actually by the body map. And so if you look at this, hopefully this will be something that is relatively new for everyone out there, but you can actually have stimulation or targeted delivery pretty much anywhere in the body. So in the head, there's something called transcutaneous or transcranial magnetic stimulation. There's deep brain stimulation. The neck has another type of stimulation. The surface has TENS units and variations on that. The back has spinal cord stimulation and dorsal root ganglion stimulation. There are other nerves on the arms and the legs that will be treated. And if you have all over body pain, oftentimes we think of using intrathecal drug delivery systems, such as, unfortunately, metastatic cancer pain. So we'll start with this one. And this has a lot of history. Deep brain stimulation is actually a neurosurgical procedure in order to treat problems in the brain. And the main things, the reason why it got started with neurosurgery is because it was treating chemical dysfunction or movement disorders that were involved in deep structures in the brain, such as Parkinson's disease, essential tremors, and other types of neurologic conditions. Surprisingly, believe it or not, there is a phase 3 trial right now that I don't believe is completed in order to treat mild Alzheimer's disease. So you can actually treat changes in memory and cognition with using electric stimulation. And for pain itself, it's been used off-label to treat a lot of central nervous system pain conditions, such as post-stroke pain and other kinds of conditions that don't seem to respond to therapies outside of that area or out on the arm or the surface of the body where the pain lies. Well, most people would prefer not to have something implanted in their brain. And so there's actually a surface way of treating a lot of conditions in the brain called transcranial magnetic stimulation. And this is a non-invasive form of brain stimulation. It's on the surface of the head. And it uses magnetic fields basically to stimulate different parts of the nerve cells in the brain. Now, the highest quality data that we have is for the treatment of depression, but at our Stanford Pain Management Lab, we've been actually doing some clinical research led by Dr. Bafi Salmasi on nerve pains or complex regional pain syndromes and other conditions. The last part is just for a little bit of fun because it looks like something out of a cartoon. However, the truth is that it really does look kind of like that. And actually, this is a patient receiving TMS. Yes, this is a little bit of an older unit, but that's sort of the setup that you have. It doesn't really touch your, you don't have to shave your hair or anything like that. It just will be over the surface of the head, and it can really treat a lot of different conditions. You need to have a couple cycles of the treatment in order to get benefit, but could be very, very effective. Now, what about the neck? Okay, so I don't know how many of you out there are biology majors or took biology for high school or college and things like that, but there's something called the vagus nerve. So what is that nerve? Well, that nerve it activates different functions in the body, especially it can change your heart rate or your stomach acid. It changes your sensation around the throat here. You may have heard of something called going vagal, which is sort of a fainting phenomenon. If somebody is having kind of stress or something like that, they may change their heart rate, they may feel kind of faint. Now, initially, by treating that nerve and implanting something internally, which is not what you're seeing here, but the initial types of treatment were for treating epilepsy and for depression. And it's interesting that you could treat it at the neck. Now there are newer devices for surface stimulation. And the first evidence of clinical trials was for treatment of resistant depression, quite effective, even just treatment of stimulation at the neck. The second was treatment of headache. And there's some data for cluster and treatment of migraine using neurostimulation at the neck, not even inside the body, just at the neck itself. You can self-administer it with some guidance and some instruction. And the last part, which will hopefully surprise many of you, is that it can actually be used to treat COVID-related respiratory distress. Now, I need to make a disclaimer here before everyone starts to go out and buy vagus nerve stimulators in order to prevent COVID. That is only for absolute areas of respiratory distress where there's something called a cytokine cascade. And so at very, very problematic parts of COVID, when someone is almost ready to go into the intensive care unit, or maybe in the intensive care unit with support, respiratory support, you can use this vagal nerve stimulation in order to decrease the amount of problems that are being developed by COVID itself. And it actually has an FDA order that it would be allowed in those kinds of circumstances. Now, this is probably a slide that you guys have seen multiple times. And the only reason I bring it back is just to make sure that everyone understands that a lot of the surface stimulation that we have, TENS units and things that are going to come up in this talk, go back to this gate-controlled theory. It's basically two Canadians that drew out a signal pathway on a napkin. And the way that I understand it is that if you bump yourself, you bump your elbow, then if you rub in that area, and how we've told our children or other friends, if you just rub in the area around it where you got the injury, that it can sort of make things feel a little bit better. And that's sort of how the gate control theory works. It's by stimulating another area, you can shut down the pain signaling and close the gate. And this was really the theory that started a lot of what's going to come forward in the next couple slides, which is TENS units, or transcutaneous electric nerve stimulation. You can see the gel pads that are on this gentleman's shoulder and back. You turn on the device. This may be a little bit of an older unit, but the principles are still the same, and you can get them now at local pharmacies or Amazon. The units are anywhere from $30 and on up, but you can actually buy them yourself in order to utilize it at home, utilize it for a half an hour or so, maybe an hour, shut it off, and you get pain relief that lasts. You use it a few times a day. And this is a low voltage electric current in the skin in order to stimulate nerve fibers for pain control. There's something called the Cochrane report, and this is a group of people that look at all the data and articles that come out on a different kind of condition or treatment. And the last one, Cochrane Report 15 on June 2015, showed that TENS units are better than placebo at reducing acute pain, and they're inexpensive, safe, and can be self-administered. So the picture down below is just one device that seems, that is actually, I think it's the #1 rated one on Amazon in the US, at least that I saw. There are multiple pain conditions that it's been studied in, including osteoarthritis, fibromyalgia, tendonitis, and back pain, and diabetic neuropathy. It seems to have some benefit, varying benefit in each of those conditions. So what about some of the other things that have happened? What has been newer since TENS units have been around for a long time? Well, there's something called deep oscillation therapy, which is really this pictograph on the right. It shows that there's a penetration into almost like a deep tissue massage. And it's FDA approved. This device is a neurostimulation device approved for muscle relaxation and increased circulation and pain relief. The aim, though, is to restore mobility and maintain muscle mobility and function. Now, it can't be self-administered. This actually you have to have a provider administer to you, either physician, physical therapist, etc. But there are devices that you can get and that should be available pretty soon. One of these that's being studied locally right now, just up from Stanford at University of California, San Francisco, is this HFIT, or high frequency impulse therapy. And this one's interesting because it uses high frequency components in order to block back pain. And that's really what they're studying it for. I like my Apple products, and I'm sorry for advertising about that, but I like my iPhone and tech devices and things like that. And so this device, you can actually have an app for it as well, and it'll help time and track when you self-administer the treatment for an hour or more a day. I don't know more about the clinical trial than what's on clinicaltrials.gov, but I would assume that you administer the treatment for an hour or so. You probably can do it for a few times per day, and then they track and see what your function and your pain scores are like. There are other things that are on the market right now too that you can purchase, and those are pulsed electromagnetic field therapy. And initially, this kind of therapy was used to treat fractures or depression, but it's got approval. The FDA approved this one on the top, Recovery RX, for post-operative pain. And there's different areas where you can get this sort of delivery device or patch basically to put it on, to strap it on and deal with your acute pain. And then the FDA this year gave clearance for an over-the-counter musculoskeletal pain Acti patch, which is listed below. Another neuromodulation device, even for an anti-inflammatory action. And then you get to things that are a little bit more interesting or kind of a little space agey. This one is a Nanotech patch, and Kylo has something with nanocapacitors. It sounds like something out of science fiction. There are, right now, they are doing some clinical trials on it. It's not approved by the FDA, but this is interesting in that it seems to have a low side effect profile, and it's also waterproof, so you can wear it when you're exercising as well. Now, there were a lot of other stimulation patterns that actually Emily asked me to discuss, and I had to group it together so it would be a little bit more cohesive, and I think some of them dovetail off of what we just talked about. And so some of the upper ones, like an H wave and interferential stimulation, I actually prescribed or had knowledge of a little bit earlier, quite a few years ago. And it seemed like they were sort of a spin-off of TENS units that just are just a little bit more comfortable, a little bit more higher frequency, that have they have a more comfortable waveform, or they just seem to have just a little different pattern that's better for certain people than a TENS unit itself. TENS unit tends to be kind of a tingly tapping type sensation that can be uncomfortable for some people over a period of time. And I think these two in the top actually tried to smooth out the delivery so it was a little better. The two that I mentioned in the middle there, neuromuscular electric stimulation or percutaneous electric stimulation, are more for where you either have to put in needles or you're trying to directly fire the muscles themselves. So neuromuscular electric stimulation is more for spinal cord injury or post-stroke in order to maintain flexibility and also motor function in a different limb. The last one, the scrambler therapy, is kind of interesting in that it interferes with pain transmission by mixing non-pain information onto it with one clinical trial showing benefit for neuropathy pain. But I know that for a fact in trying to get some of these approved in the past, there are some insurance coverage issues, and I'm sure they will vary by your state in order to obtain these ones. Moving on, just to sort of fill in, we're going to move to the spinal column right now. And so spinal cord stimulation, or medicine by Edison, as one of my fellows used to call it, is using electric fields at the axial spine or the midline in order to treat pain as an alternative to opioids. And while we think of it as being most effective for failed back surgery syndrome or multiple back surgeries and pain, it also can be effective for complex regional pain syndrome and many other areas now. We've been doing trials and treatments for all what's listed below, including abdominal pain, pelvic pain, even some non-cardiac chest pain and things like that. What I thought might be helpful just briefly is to talk about who is the right candidate and what do you look for in order to be a candidate for this. And so as a physician, what we think of is some of these questions that you see on the screen here or on the slide deck, which is, do you have back and leg pain? Do you have complex regional pain syndrome or a specific neurologic condition? Other nerve pain conditions and visceral pain conditions can be effective. We're still in the clinical trials for some of them right now, including abdominal pain, etc. Have you done interdisciplinary therapies? So we call this the 4 legs of the chair, where in order to have a stable pain management framework, one of the legs of the chair is targeted medicines, oral medicines, usually non-opioids. The second leg may be targeted interventions, including spinal cord stimulation, but not only that. Do you have a physical activity function plan? It's the only way we can gauge whether you're getting better or not, is what you're able to do. How active can you be? And then the fourth leg of the chair, maybe the most important, is the whole mind-body connection. Because when you have pain that doesn't go away simply, it's difficult, and it creates problems for, it sort of shrinks your life because you just don't want to do or participate with other people and do activities that you enjoy. What we do is also ask about some social habits. Tobacco, believe it or not, can prevent wound healing. And typically we have people off of tobacco at least for a month. Neurosurgery, spine surgeons actually encourage 2 months in order to make sure wound healing is better. And then if there are any structural problems or medical issues with labs or just the placement of the device itself, what we will do is have something called a neuromodulation conference at Stanford. And that involves multiple physicians, not just pain management, but internal medicine, neurology, etc. We'll have pain management psychologists involved in discussion, and we pick the best device that will fit your pain condition, and it's our best guidance on what it could be. And it may not be what we thought of initially or what you were expecting for spinal cord stimulation or a certain technique. There may be things to do before that even. So that's our plan with that. What are some of the newest spinal cord stimulation patterns? Some of these are all about changing that signaling from the tapping kind of tingly sensation to something you can't feel. So there's one that's a high frequency stimulation at 10,000 kilohertz that you cannot feel it. It just goes too fast. Burst DR from another company is utilizing something that is a stimulation that mimics your action potentials or the way that nerves fire, sort of 5 pulses per burst. There's another one that's coming out that's called closed loop stimulation, where you actually get feedback from the spinal cord itself through the leads in order to make adjustments when you're moving up and down, when you're lying down or standing up. And then the last one is there may be combinations of the old traditional spinal cord stimulation where you do feel the tingling and tapping with these novel waveforms above, any of them, including high frequency or burst. And there's a theory out there about something called chaos stimulation, which means that maybe it's possible to use all of them above, but in a sort of unpredictable manner in order to treat your pain condition so that the durability or the effectiveness of spinal cord stimulation doesn't get predictable and it lasts longer. This is just a cartoon picture, or actually a picture of a patient who had dorsal root ganglion stimulation in place. I just want to make a comment that rather than just for treatment of complex regional pain syndrome or specific nerve conditions, we are using it for specific nerve injury neuralgia states, including ilioinguinal neuralgias, pelvic pain, and post-herpetic neuralgias in a specific area along the ribs. But that leads me to what are the kinds of stimulation that we have for arm and leg pain. The older devices, we just took the leads above like this and put them along the nerves, and they were big, they're a little bit difficult to implant, and also the generators were kind of huge for the peripheral nerves that we were trying to treat. Nowadays, we have newer technology, smaller wires, smaller batteries. You just wear a pack like what you see there. And they can either be implanted permanently, where they're placed under an ultrasound, you wear a small profile battery, or you can have a temporary one for 60 days. Sprint has a device where, or the Sprint device is used for back and peripheral pain, where you have extended back pain relief, even taking it out after 2 months, or you use it actually for acute surgical pain, implant it even before the surgery in order to treat post-surgical pain without any oral opioids or other medications. sort of the last thing to wrap this up is where's the treatment for all over body pain, or pains that don't just occupy one nerve or one nerve on the arm or up in the neck or any specific area. And this is really where intrathecal pump or intrathecal drug delivery systems come in, where we use targeted medicines in the spinal fluid in order to treat pain as an alternative to all the other kinds of oral and neurostimulation devices that have come before. And some of the indications for intrathecal therapy are what you would expect, like cancer pain that has metastasized. There is, believe it or not, a case series for complex regional pain syndrome, which I'll get to in just one moment with one specific drug. But sometimes abdominal pains and pelvic pains, they just don't, they don't respond as well to spinal cord stimulation all the time. And there are other kinds of pain conditions where you just don't get as much benefit with a kind of targeted focal stimulation pattern. The FDA approved drugs, and I need to make sure that I stay on topic here, is that there are really two drugs for intrathecal delivery that are FDA approved currently: morphine and a medicine called ziconotide that I'll talk to you about in a minute. And then clonidine is really specified for epidural use, and baclofen is for spinal cord injury spasm pain or multiple sclerosis spasm type pain. Now, this last kind of fun slide is about this snail, and the snail is actually called Conus magus, which is the magician cone snail from Southeast Asia. And so there's this drug that is developed from it, a conotoxin called ziconotide. What happens is the snail has this neurotoxin on the proboscis, and the fish tries to eat the proboscis. When that happens, the snail actually delivers neurotoxins to the fish and then eventually paralyzes the fish and eats the fish. That's not what happens with patients, but what we did is there was a development of a very potent chemical that really worked well for cancer and non-cancer pain in patients that did not respond to high-dose opioids or spinal cord stimulation and other medicines at that time. And it can be effective when no other drug has been effective, and you can only deliver it intrathecally via this pump. And our case series for complex regional pain syndrome didn't cure everyone with complex regional pain syndrome, but many people got really significantly better, so much so that a lot of the symptoms of the disease sort of resolved and went away. I even had one patient where we eventually just tapered off the medicine and took out the pump because that person didn't need it anymore. So let's summarize what happened. Hopefully this is where I led us with this talk, which is that there's a lot of things that neuromodulation can help with. It's really electricity or targeted medicines for acute and chronic pain. There are a lot of self-administered therapies available now, not just TENS units, but Recovery RX, ActiPatch, many of the things that I mentioned above. This vagal nerve stimulation or vagus nerve stimulation used for headache and potentially for really bad cases of COVID, something I never thought of using neurostimulation for. Spinal cord stimulation and DRG stimulation, they have great evidence for back and leg pain and complex regional pain syndromes, but we're starting to expand it to other peripheral neuropathies, knee pains, and other kinds of pain conditions, and getting more and more data all the time for it. Intrathecal drug delivery system, especially for cancer pain patients, very, very effective. Also for non-cancer too, when other forms of neurostimulation are not working. And so what's the future? The future is really now. High frequency stimulation, you can't feel the tingling. Dorsal root stimulation, very specific extremity regions. And peripheral nerve stimulators can be implanted for wireless stimulation now. I think it's really fascinating how fast things have grown over the past 5 to 7 years. I've been really fortunate to be involved in the care for many people like you, and just to be involved in sort of a kind of a fast and really interesting area of pain management. Thank you for listening. And this is our address. This is a picture of Stanford University. And just, I forgot to say too, the background that I'm in right now, this is not my house or anything like that. That is actually the interior of the new Stanford Hospital. If any of you, well, hopefully not right now, but when things get a little better, it's a pretty remarkable place to come and visit.
Awesome. That was so fascinating and so much information. I'm sure everyone is feeling the same way. Just like, so I thank you so much for doing that and giving such a broad overview of all those different types of therapies. We have a ton of questions coming in,
Okay.
which is great. So I'm going to do my best to get to as many of them as we can. So if you have a question still, you can type those in, but we'll see what we can get to as speedily as possible. So one question we had from Facebook, which I thought was kind of interesting, was about the newer methods, the newer patterns you were talking about, and whether there are clinical trials going on for those or if they're currently available already.
Oh, okay. Yes. So we tried to be very. I tried to make sure that I didn't try to go forward for and promote any specific company or device or anything like that. So yes. So high frequency stimulation is based on a company here in Menlo, or actually Redwood City now, called Nevro, and that is available right now. And we've been utilizing that for even for people that have had older systems put in that have the tingling sensation that it just didn't work, or it has the effectiveness has kind of gone away. We've been able to retrial them with high frequency stimulation, which is Nevro, and also with Burst DR, which is from a company called Abbott that was supportive of US Pain Foundation as well. Some of the other companies, there's a company called Boston Scientific that has the capacity to do many of the other kinds of higher frequency stimulation and a burst type method. And that's where some of this combination therapy really came in that you can adjust to the patient and you can adjust what feels comfortable to the patient, because not everyone responds to higher frequency where they don't feel what's going on. And so some people actually like to feel it. And just because you have an older system, it doesn't mean it's bad. It just means that it's just different. It just doesn't have this newer type of technology. The other thing too, I can say is if you do have an older system, you can change out the battery with your company. It could be the kinds of companies we have are Medtronic or Abbott or Boston and things like that. And oftentimes get some of these newer stimulation patterns too without having to replace the whole thing and do so. It's a much easier surgery, believe me. So.
Great, thank you. And just as a reminder to everyone, we certainly don't, as Dr. Leong's indicating, we certainly don't endorse any specific brand or company. It's just sometimes there are therapies that are sort of synonymous with a specific brand. So just keep that in mind. So I have some other questions. A few people were asking about interactions between devices, which I thought was really interesting because, people are thinking about combining a couple of neuromodulation therapies. So one question someone had was about spinal cord stimulation and dry needling and whether they could use e-stimulation with the needles if the spinal cord stimulator is turned off.
Okay, well, okay, yeah, turning off is a good one. That's one. Two is the depth of where your e-stimulation is going is probably not going to affect the spinal cord stimulator. Obviously, you know where your battery pack is. If you have it on your bottom and things like that, you don't probably want to e-stimulate around that area. But if you are treating your, and I'm just assuming, if you treat your upper neck and back and things like that, and you have a traditional placement of spinal cord stimulation, which is at about mid-thoracic, T8, T9, so in the middle of your back, you're probably not going to have any issues with it.
Okay. And along the same lines, someone else was asking about spinal cord stimulators or TENS units with AEDs and defibrillators, and whether, like, should they wear a, a medical ID bracelet, or, that says, like, don't use an AED, or what would you suggest about that?
Okay, well, let's see. So first of all, I just want to make sure I understand the question. So did they have a pacemaker in? Because,
Sorry, so I think they have a spinal
yeah,
cord stimulator, and they also sometimes use TENS units as well.
oh, okay, I see. Let's see. So again, if it's a spinal cord stimulator, you are allowed to use a TENS unit as long as it's away from any kind of area where you think it's your leads or your battery pack are positioned. Um, Look, if you're having a heart problem, you got to use the EAD. It doesn't matter what. I mean, if that's what's available, and you need a resuscitation, where I would say that most medical providers, anybody, EMT, a physician, whatever, nurse, we would have to use the AED just to bring you back. Um, uh, be that as it may, you actually, even having a pacemaker, you can have a spinal cord stimulator with some conditions. And I would say that I have to say that a little bit carefully, but you need to ask your physician and your cardiologist and your pain management physician. But it's been done. It has been done. So.
Okay. Thank you. Just something I had never thought about personally. Um, and let's see here. And someone else was asking about implanted devices and whether they're okay to have with other implanted metals, like knee replacements, or if you have rods in your spine.
Yes. Actually, the truth is that for back pain, for failed back surgery syndrome, there are a lot of patients that we see that have pedicle screws and some metal structures there. Remember, the leads themselves for the back. I actually took that picture out. I should have left it in. The picture shows that your back nerves actually come out at around T8 and T9, and then they spread out. And so that's why the leads are up a little bit higher than what you would expect. You would think, oh, back pain, you're just going to leave it in my low back. It actually doesn't work like that. You actually go up higher before the nerve starts to branch out. So as long as we have access, remember I said we need to have an MRI or a CT scan with a CT scan, CT Milo, in order to make sure there's no obstruction in putting the leads. It's really not much of a problem. And then last thing is that you could get not just percutaneous leads, but a neurosurgically implanted paddle where they have to take a small bit of bone out and then just slip it in underneath. And so you can get neurostimulation, even if it seems technically harder because of metal below.
Um, and one last question on sort of interactions with like different types of neuromodulation. One of our audience members has an intrathecal pump, and they were wondering if they could use anything other than just a TENS to help with their nerve pain, in addition to the pain pump.
Okay. Without knowing exactly what's in the pain pump, there are other solutions that you can use, and some of them are, again, we're trying to stay on label with FDA, but there are other kinds of medicines in the pain pump that can be used to treat nerve pain. Ziconotide, or the trade name is called Prialt, is one that seems a little bit better for nerve pain than opioids. There are local anesthetics that are non-FDA approved for pain pumps and other things that can be put in for nerve pain. Just because you have a pump, it doesn't mean that you couldn't have a spinal cord stimulator trial or peripheral nerve stimulators. That doesn't preclude it. So there are other kinds of treatments that are available. I would either ask your pain management provider in your or physician in your area, or perhaps seek out another evaluation or recommendation.
Okay, great. Thank you. So moving on from sort of the interactions between different kinds of therapies, or different devices or implants, another question we've gotten from a few different people in a few different ways is, what type of clinician or provider is best to see to talk about implanted devices or external devices, and help figure out which one is the best for your specific
Uh,
condition?
that's a good question. I mean, look, the truth is that you we do things a certain way at Stanford, and we hope that it's one of the better ways. But I think that most pain management providers or physicians that have come out recently and that are in practice um, should know about many of these technologies, if not all these technologies that I've discussed. So I think uh, maybe a little bit of reference from your primary care physician, somebody who has some notoriety in your community. There's lots of great pain management specialists all over the country. Um, we with unfortunately with COVID, we are, well, fortunately or unfortunately, we're doing a lot of more video visits now too. And so you can actually see people from a little bit farther in your state or area, or even out of your state, in order to consider getting assessments. So I'll leave it at that. But I would I would say that I'd recommend somebody who has a pain management fellowship and that has had some training in neurostimulation within the last 10, 20 years should probably be familiar with most of what I've just talked about.
Okay, thank you. So we also have a lot of questions about spinal cord stimulation specifically, which is always, I think, patients are interested in that topic a lot. And one question we had gotten was about someone who they have a stimulator implanted currently. It's been helpful, but they feel like they still have some pain. What would you say to someone about their options if they already have an implant, but they're interested in getting more relief as far as maybe a different device or
Okay.
combining another therapy with it?
So let's see. So oftentimes within the past like 5 to 7 years, so let's say within the past decade, there have been advances or improvements in the stimulation, even just in the battery pack itself. So what I would say for just in general, for someone who's got a neurostimulation device, worked okay in the beginning, maybe not so good right now, is to check back in with their physician who implanted it and with the company who is still supporting them, and see if there's a newer generator or a newer kind of waveform that can be done in order to improve the ability. Because oftentimes these waveforms and devices that be improved just by changing the battery pack or the generator out already. Um, Patients are allowed to have, in general, 2 spinal cord stimulator trials or 2 major device trials in their lifetime. So if one doesn't work as well, you could trial a second device that may seem like it fits you better. You want to go to an institution or to a practice, a pain management physician that would have that kind of therapy and could give the pluses and minuses, because not all devices are successful. And but the thing is too, neurostimulation is one of these things. It's really cool because you can actually trial the device. You get a test run first before you actually implant it. So I mean, how many things in medicine do we get to do that in? I mean, usually you get a medicine, you get a pill, you got to try it for months and months. You don't know if it's going to work. This one, you're going to know within 7 to 10 days. So.
Right. No, it's so cool. I think a big takeaway for me, at least today, is that even as many different categories of stimulation as there are within neuromodulation, each subcategory has more subcategories. So there really are so many different options and things to try. And it really kind of depends on your specific condition. So on the note of specific conditions, we did get a few questions that are kind of, specific to certain disease states. So I was going to ask just about a few of those that we got, and they were asking specifically about spinal cord stimulation. So, and I know I'll just kind of list them and then you can.
Yeah, go ahead. Yeah, you
Yeah.
can do a grab bag. Just say one, and then I'll
Okay.
okay.
So someone asked about adhesive arachnoiditis, which I hope I
Okay.
pronounced
Yeah,
right.
no. So arachnoiditis, it's like spider webs in the back. It's basically from they call it from either failed back surgery syndrome, could have had multiple surgeries, or had a lot of epidural steroid injections and things. Uh, uh, that's one of the primary things that we put implant spinal cord stimulation systems for. So could be very effective. A lot of the newer systems will work with either one, HF10, high frequency stimulation, burst ER. A lot of them will work. Boston Scientific systems too. So.
Okay. Another one was for lower extremity and let's see here, and radiculopathy.
Yeah, actually, that was the most effective type of syndrome that worked with even traditional spinal cord stimulation. So if you had back pain alone, stimulation before wouldn't work as well. But if you had back and leg pain, it actually worked a lot better. So any of the systems probably could benefit that condition.
Okay. And then two more kind of unique ones that people had asked about. One was implanted devices for cerebral palsy, and then another one was for relapsing remitting multiple sclerosis. So not,
Okay.
yeah.
Yeah. Okay. So I'm going to have to go out a little bit on a limb for those two. So cerebral palsy, more of a movement disorder type thing. I would imagine that some people, and not everyone's going to want this, who have like a movement disorder, dystonia type problem with cerebral palsy could benefit from that deep brain stimulation. Again, not everyone wants to do that. It would be probably challenging to do more spinal cord stimulation for that. However, we do have peripheral nerve stimulator systems now that will help with arm or leg pain that are actually quite tiny, and then just have that small battery pack that you put on. So that could be something beneficial. I haven't seen a clinical trial on it at all. And then let's see, for multiple sclerosis pain, typically we think of fatigue and spasm and things like that. Traditionally, patients have been placed on antispasm medicines like baclofen or tizanidine. Xanaflex is the trade name for that. And if they got some side effect profile from that, then we would think about actually an intraspinal pump or intrathecal pump with baclofen for it. For pain per se, for multiple sclerosis, it would depend on the region. But again, most of these devices can be worked with for neck pain, for arm pain, for mid-back pain, for leg pain. So I'd actually have to see it, sorry, to kind of know.
No worries. And I guess like a general question, because we're getting so many questions from people about sort of their specific condition and their symptoms. So what kind of general advice would you give to patients about, how to find out if their condition is right for a certain therapy? Like what kind of, where should they look, or what kinds of things should they look out for when researching specific therapy?
Well, that's the thing right now. So spinal cord stimulation and pretty much any drug or device is sort of gauged on what the FDA approved it for. And so spinal cord stimulation was approved for back and leg pain, for failed back surgery syndrome, multiple back surgery type of problems, and complex regional pain syndrome. I think the best option is really to go to your local pain management or community pain management provider or academic center and just actually get a consultation and just to find out what is available. And it may not just be neuromodulation or neurostimulation. It could be different medicines and things like that. There are things that many patients just aren't aware of with newer drugs and newer techniques, even physical therapy type aids. You want to make sure that you cover all your bases. And I like to think that neuromodulation makes a huge change compared to others, but we also put it in the framework that you have to do all the four legs of the chair stuff with medicines, targeted injections, not just implantable devices, physical rehab, and then also pain management, coping strategy, psychology too.
Right. Right. That's something we talk a lot about at US Pain is that you have to combine a lot of different therapies usually, and there's rarely one, silver bullet for someone's pain. Once in a while, if you're lucky, but most of us have to find a few things and sort of use them together. So a couple more questions. I know we're coming up to the end of our hour, and I know there's a lot of you that ask questions that we didn't get to, but those questions are really helpful to us in knowing what kinds of information you're looking for, and it could help us sort of plan for future education, maybe some resources or maybe an FAQs document and that sort of thing. So don't feel bad if your question was not answered today. But just a couple more things. One thing that we didn't talk about much today, maybe touched on a little bit, was affordability. And we've had a few questions about that and sort of what you've seen as far as, whether private insurers tend to cover these things, but also, Medicare and Medicaid. And I don't know, it's a big question, obviously, because so many different therapies, but I
Yeah.
don't have any sort of general.
Well, okay. No, you're smart about that. Okay, so let me try to do this quickly. So anything that is FDA approved, it should be covered by private insurance and Medicare. Now, it doesn't mean that they're going to offer to approve it immediately. It may mean that we have to set up all the things about the four legs of the chair. You've done physical therapy. You've done all these other things to kind of build up to it. And that's it's not just to make you better or make us better, but also to just make sure that when we submit the claim for it or submit for the future therapy, it makes sense that we led to that point. Now, some of the ones that are out of pocket, like the HFIT and things like that, I don't know. Actually, I'm not sure. Usually, FDA approved devices are covered, but not always. And for a TENS unit, I'll be honest with you, and it depends on your finances and things like that, but you can get a TENS unit for as low as $30 on Amazon. Some of the other units like H-Wave and interferential units, they're more. So they're hundreds to 200. It's, money is still money, and you would rather that the insurance company would pay for it, but they're not usually in the realm of you cannot afford it at all if you save, I guess. But the higher ticket ones, obviously you want insurance to cover, and most of the time they will with the right background work.
Right. And the good thing too is like you're talking about with implanted devices, you often can do a trial first, but that's the same with some external devices as well. Companies often seem to offer like a 7-day or 2-week trial to see if it really helps you. Because I know a lot of people are willing to spend the money if it does help them, but you don't want to spend money on something and find out it doesn't work. So we're at 2:00. I have 2 little questions about external devices, if
Yeah.
you're able to. Okay.
Sure.
So someone was asking about the difference between TENS units and NMES, which I believe is neuromuscular electrical stimulation.
Right. I think we covered it briefly. I mean, one is more for activating the muscles itself. The TENS unit is not supposed to stimulate the muscle itself to fire. It's actually just causing a tingling sensation in order to activate that gate theory to blunt the pain before it goes to the brain. So they're a little bit different in the way that they're structured or their intention is going to be. If it helps for pain for you, that's great. But I think that they're not quite the same.
Okay. And then last question on external devices. Do you have an experience with pulsed electromagnetic fields? Hopefully I said that right. Specifically for CRPS.
Okay, so the truth is no, I don't. I haven't prescribed it for CRPS, but I do know that anecdotally there are some people that are using it for treatment of CRPS.
Mm-hmm.
We tend to stay. I'm at a big academic center, so I have to stay with the tried and true that I can support from evidence and things. And so we tend to use more medicines, sympathetic blocks if needed, if indicated, and honestly, with spinal cord stimulation and peripheral nerve stimulation work really, really well for CRPS for many, many patients.
Great, thank you. Well, so that was all the questions that we could get to today, guys. And I know we kind of jumped around from some general questions to some specific ones. But again, we'll definitely use those questions to try to figure out some additional resources. Someone just brought up in Facebook about maybe doing a future webinar on implanted devices and insurance coverage issues, for example. So we'll definitely, so many good comments and feedback from you all. We'll definitely find a way to try to get you some of those answers, maybe in some other form. And we've also heard just a lot of thanks to you, Dr. Leong, about just sharing your expertise and time. Even some patients who've noticed that they're in your area, so they're going to see if they can come and
yeah. Okay, so I mean, I don't want to self-advertise here, but yeah, we are open. So Stanford University, we actually do video visits for new patients and for returns. So we've been seeing lots of people that have been established from Central Valley, from down south and things like that. I mean, I and as well as my whole group, and I have to thank Dr. Salmasi, who's my subdirector for quality assurance for spinal cord stimulation, and all of my other faculty that are involved with it. We all want to help you, and so I think I put my phone number on the bottom of that thing down there, but I mean, it should be pretty easy to find out for if you just look up Stanford Pain Management Center. Primary care physician referral, we see all insurances, happy to help.
Definitely. And we'll be posting the recording of this on our website eventually, so you can always refer back to it if you want to, because again, I know that that was a lot of information, but again, we're getting a ton of thanks in the chat to you, Dr. Leong. So I have just a few last housekeeping items. So I am going to share my screen with you. Just give me 1 second. So I wanted to just share that we do have one more event next week. So for those of you who are really interested in the implanted devices specifically, including spinal cord stimulators, we're actually going to hear from patients next week because obviously it's great. We love hearing from experts and getting sort of the science and clinical background for these devices and therapies, but it's also nice to hear from patients who have lived experiences with using them. So next Thursday, we'll have a panel discussion that will be moderated by our CEO. So we'd love to see you there. If you'd like to join us, you can register at the bottom, uspainfoundation.org/November. That is also where you can learn about the face mask. If you want to receive that and earn credit towards getting that, we'd love to send one out to you. And we also do have some other resources there about neuromodulation, some handouts about questions or considerations for spinal cord stimulators. We have a list of some different types, kind of a quick sheet for different types of neuromodulation, and a few other tools there. We're also posting myths and facts on social media all month about neuromodulation in general. So we have a lot of content out there. We hope that you will check it out. But we really appreciate you joining us today and spending your afternoon or morning hearing about neuromodulation therapies. So a huge thank you to Dr. Leong for sharing your expertise with us. We really appreciate it. And thanks also to our sponsors again, Boston Scientific and Abbott. We appreciate your help. So thanks everyone, and we will hopefully see you next Thursday. All right. Thank you again. Take care.